Yeah. So we're moving into our business innovation section, which of course we've already talked a little bit about that with our last speaker. Our first speaker is Dr. Brian Dixon. And so he actually sent in a recording. So we're going to listen to his recording. He is at Regenstrief Institute, and I'll read his little bio here. Dr. Brian Dixon currently serves as the Director of Public Health Informatics for Regenstrief Institute and the IU Richard and Fairbanks School of Public Health. He is a co-principal investigator for a multi-year P15 grant, which I was a part of, funded by the U.S. National Library of Medicine to mentor research scientists in public and population health informatics. Dr. Dixon also earned his Bachelor's of Arts in Computer Science from DePaul University, his Master's of Public Affairs from Indiana University, and a Doctor of Philosophy in Health Informatics from Indiana University. So I'm so happy that we were able to hear his talk, although he wasn't able to be here in person. So give me just a second here, and I will make sure that we can hear this.
Hello, my name is Brian Dixon, and I am a professor at the Richard M. Fairbanks School of Public Health at the Indiana University Indianapolis campus. And I'm also the Director of Public Health Informatics at the Regenstrief Institute, also located in Indianapolis, Indiana. What I'd like to talk with you about today are three things. First, we'll talk about the Fairbanks School of Public Health and Regenstrief Institute's programs and activities in the public health informatics space, so you understand kind of the context from which I'm coming. Second, I'll talk about trends at the global and national and state level related to public health informatics, talking about what's happening today from my perspective. And then I'd like to talk through opportunities for both innovation and training. These, I think, are things that will interest you as either students or early career professionals in public health informatics on how you can get involved with some of these activities. First, I'd just like to sort of mention as way of background that I am the co-editor of the book from Springer on public health informatics and information systems. That textbook is pretty common in many training programs, but also used by professionals in terms of understanding kind of the broader field of public health informatics. Our field, of course, brings methods, knowledge, and theories from both the information science and computer science fields in support of public health practice. Okay, so a little bit about my organization, the Regenstrief Institute. We're over 50 years old as a research institution, going back to the late 1960s, early 1970s. Our institute on how we improve the delivery of healthcare and health services. Main sort of centers and areas of activity. The first one being in aging research, health services research, which is broad, includes topics such as health equity, learning health systems, which is how health systems kind of use their data to feedback and improve kind of the delivery of their services. And then, of course, we have our Center for Biomedical Informatics, which focuses on all things related to information exchange, standardization, interoperability, data management, and information management. I am currently the interim director for our Center for Biomedical Informatics. We have a number of pillars of work that we support in the broad field of biomedical informatics. It includes everything from clinical informatics, which are applications that support direct patient care, to our global health informatics team, which works around the world outside the U.S., as the name would imply, to really implement technologies for both patient care as well as public health. We have a program that I direct on public health informatics, which is focused primarily on supporting state, local, and federal public health agencies and organizations in the U.S. We have a program on dental health informatics, which is a partnership with the School of Dentistry at IU. We have a program focused on using informatics to support learning health system cycles and analyses inside of healthcare systems. And then we have a group that's focused on AI, machine learning, and analytics in the healthcare space. So those are kind of the areas we work in. I'm going to talk mostly in this talk about our public health informatics pillar, but wanted you to be aware of the others. Okay, a little bit about the Richard and Fairbanks School of Public Health. This is the other hat that I wear, which is as a faculty member at IU Indianapolis in the School of Public Health. Our school is a fairly standard school of public health with multiple departments, multiple academic programs focused on things like epidemiology, health policy management, community and global health activities. So we do a lot of the things that many other schools do. Of course, our school tries to be innovative in its thinking and approaches to solving public health problems. At the School of Public Health, some ways that we are more innovative, I think, than other schools of public health is that we have built out and put emphasis on building a pipeline for health informatics work that supports the public health practice. So we have an undergraduate degree that's in partnership with the School of Informatics, Computing, and Engineering here at IU Indianapolis that focuses on preparing undergraduates to work at the intersection of data science and healthcare. We have master's programs in public health informatics. We also have an MS in data science in partnership with the Luddy School of Informatics and Computing. And then we have, at our doctoral program, we have a minor concentration in population health analytics. I wanted to talk a little bit about our MPH. It's a core degree. We require, for example, that students in this program have a core foundation in public health, but they also focus on informatics. So they take courses on analytics and GIS and visualization of data and data management that really help them support public health practice in terms of the implementation and operations of information systems in the context of, say, STD programs or chronic disease management or environmental health. So that is, I think, a degree program, which I'll talk a little bit later, is part of some activity in the U.S., but is certainly on the leading edge of what's happening in education around public health informatics. I also wanted to mention our training program in public health informatics. This is a program that is federally sponsored. I'll talk a little bit about the details of it, but we really try to recruit individuals who are seeking to do a PhD in a core public health field to augment that core educational program with training in informatics so that they can go into research at CDC or state health department. They can go into academia, they could go into industry to provide research in the area of public and population health informatics. This program is funded by the National Library of Medicine. It's part of what the NLM calls its T15 training programs in biomedical informatics. There's a link at the bottom of the slide that will take you to the NLM page. There are 18 programs across the U.S. that are funded by NLM to do training at the doctoral and postdoctoral level in biomedical informatics. Our program focuses on public health. We focus on taking individuals who are doing, for example, a PhD in epidemiology, cross-training them in informatics, and then putting them to work on applied research projects that benefit public health. Similarly, postdoctoral students are learning how to become independent research scientists while working on projects that benefit public health agencies. We have partners at the state and local level in Indiana where we do that. Whether you do this kind of training at Indiana or another NLM funded site, it's a fantastic program. And if you're interested in doctoral level work, this would be a fantastic program for you to check out. Okay, so now let me talk about some of the opportunities and trends that are happening in our field of public health informatics. A lot of it is trying to take the lessons of the COVID pandemic and now move beyond COVID so that we apply informatics techniques and solutions to current public health problems as we come out of the pandemic. First, I would like to mention a report that is freely available in the Journal of the American Medical Informatics Association, which I had the pleasure of co-leading a workshop symposium of the American College of Medical Informatics that discuss sort of how do we transform the public health infrastructure in the U.S. coming out of the pandemic. And so in this report, it talks about a lot of the things that are happening and need to happen in the public health space. So I'm going to touch on some of these aspects in my presentation today, but if you want sort of a more deeper discussion of some of these items, I would point you at this report, which is open access. All right, the first thing that I want to talk about is the Data Modernization Initiative, or DMI. You may hear about this in some of the other presentations at the conference. That's because it's sort of the big federal level, national scope project that is funded and focused by CDC. What this initiative is trying to do fundamentally is to enhance and update the infrastructure in the U.S. for public health systems. And that's everything for the infrastructure inside of a public health agency at a local level or at a state level. And it's also about kind of connecting them all together. At the core of DMI is really a focus not just on sort of applications and information technology, but really data. Trying to make public health data accessible, timely, fluid so that it flows between the various levels of public health, trying to integrate it across all the various programs that public health has had. One of the challenges we've had historically has been very siloed sort of information systems, but also siloed data. And so now with the DMI and the strategy at the national level, we're really focused on trying to integrate data across the spectrum, connecting not only clinical systems with public health systems, but also connecting within public health our systems so that we can have more complete data when we need it for an emerging public health event or for routine public health work. To go along with the DMI, CDC has published and now updated its public health data strategy. So again, data is at the core of informatics and the work that we do, and it's certainly the core of the activities at the national and state level to support a vision where data can be connected and used and analyzed using the latest and greatest in terms of technology, everything from AI to just cloud computing to now quantum computing, right? As we think forward into the future, really how do we take advantage of those computational tools that are available to unlock the power of data and enable public health to make decisions rapidly, whether it be at the very, very local level within a city or county, or at the national level related to trends or an emergent health issue. I wanted to point out that this work is also happening at a global scale. So I'm going to talk a lot about what's happening in the US, but what's happening at the WHO is very, very similar. They have put together a global strategy on digital health. So one of the things that's different between the US, we call it the data modernization and the data strategy. At the national, international level, rather, we're calling it digital health strategy. And this is everything from countries' information systems within a clinical environment all the way up to the Ministry of Health level, that's focused on how ministries can ensure that their data from the clinical systems and from their various levels are also integrated, how they can be used in a timely way to make decisions about population health. So what's happening in the US is just part of what's really happening globally, and there's a lot of discussions between countries on how to work together to sort of achieve these aims, both at regional levels, like for example within the Africa CDC, at the continent level, or across continents or across boundaries, like what's happening in the European Union. This is an example from Denmark, and so the top is mostly in Danish, so you don't have to read all of that. But I think it's important to recognize that over the last sort of 2 decades, there's been a real effort at the international level to incrementally move from sort of getting electronic medical records implemented in countries so that you can capture data electronically in care settings to connecting the dots at the ministry level. So the current effort at the international level of sort of digital health strategies has really built upon a foundation that has really been growing over years, so that countries like Denmark, for example, are now focusing on things like engaging citizens directly into their health, whereas 15 years ago it was really about laying the foundations for infrastructure. So we see this spectrum across different countries. Some countries are still just laying the foundation that they need for 10 years down the road. Others are trying to take infrastructure they've developed over the last 5 to 10 years and now capitalize on that. Okay, so that's a little bit about what's happening sort of at the 30,000 foot view, both in the US and internationally. Now let's talk about some opportunities for innovation and training in this space of public health informatics. Some of the work that we're doing in Indiana is really focused on building that architecture, laying that foundation, connecting the dots. So for example, in Indiana, in the center part of the screen, you see this thing called the Health Information Exchange. That is something that's now over 20 years old in Indiana. It connects hospitals and clinics and payers and physician offices, along with public health, connects them together, enables them to share data. What that allows us to do is sort of have a statewide view of, say, who has diabetes, right? Now, that's very important from a clinical perspective if you want to know sort of, are my patients with diabetes getting the recommended care from a healthcare system delivery perspective or from a provider perspective. But it's also important from a public health. And so what we've started to do is connect that infrastructure with public health, which is the stuff on the left-hand side of the screen, connecting it to its infectious disease surveillance system called NBS, which is there's about 28 states now that use NBS in the US. There's also an immunization information registry, which we call CHIRP in Indiana, and connecting that with vital records, which is birth certificates and death certificates. So if we can bring that data from public health together with the clinical data, then we can start to build cohorts of populations that enable us to do analysis and AI and all the other cool technology things that we want to do. So what you see in the bottom right-hand corner is a picture of our COVID-19 dashboard. We put that together relatively quickly during the pandemic because we had some of these other pieces pulled together. We've now since started to do more integration on the public health side under DMI that enables us to do other things that I'll talk about next. But part of what we're doing right now is building architecture, and we need new innovative ideas around how best to integrate data, how best to analyze some of these very large data sets. So that's where you could potentially play a role. This is a very traditional sort of approach that we're taking to extract, transform, and load data, or ETL data, out of clinical systems, move them up, sort of build population level data sets, do that analysis, and then share the aggregated data, and put that aggregated data into analytical software. So the example here is, as data flows from the EHR to our health information exchange, it then gets put into a data set that is used by a software program called PopMedNet, which was designed for population level analysis. That then creates aggregated data which can be shared outside of the jurisdiction, and that gets put into an analytical platform called Riskscape, which does visualization of data, creates trend lines, allows for decision makers to look at that data and understand what's happening with that population, both at a state level and then nationally. So this is a good example of a project we're working on now, and one that I think is really representative of what DMI is hoping to achieve nationally eventually. Other examples of where we're trying to modernize data and enhance information systems can be seen in our project around sickle cell disease data collection. The point of this program is to really enhance how we collect data on sickle cell disease, not only among babies who are born with it and get screened at the time they're born, but also for adults who are living with this disease. We have partners across the Department of Health, the Medicaid program, the children's hospitals, our program, and other providers like the Indiana Hemophilia and Thrombosis Center, which is a major provider of care to people with sickle cell disease in Indiana. So all of us are working together on this project. The project is really focused around creating tools like this dashboard you see here. This tool allows us to visualize where people living with sickle cell disease are located, and then we can start to dig down into, are they engaged in care? Are they getting the right treatments? Are they living well in their community? And so in this first version, we're looking at sort of outcomes such as death and hospitalizations for people living with sickle cell disease, but we can also drill down into whether they're getting treatments and what is the predominant treatment for these individuals, and we can then monitor this population over time. So this is an example of the kind of tools that we're trying to build under sort of this platform of the Data Modernization Initiative that will really help public health make decisions. The other cool thing about this project is we're making this dashboard public, and we're allowing community-based organizations that work with sickle cell disease communities to use this data to write grants and get money to do things for families, to help connect people to educational resources. So we have a lot of other things we want to try to do once we have data tools like this that enable us to then ensure people are living longer and better, even though they have a disease like SCD. The other kind of tools that we're trying to create similarly envision or visualize data on chronic diseases like cardiovascular disease. That's what you see here is cardiovascular disease rates by census tract within Marion County, where our institution is located. And this helps the health department to understand where are those pockets of high cardiovascular disease, since cardiovascular disease is associated with a number of other sort of complications and diseases. If we can prevent cardiovascular disease, then we can make a huge impact on health. So if we can find where there's high risk, we can then provide education programs, we can provide intervention programs, we can do more screening to make sure people are getting the care that they need to manage their cardiovascular disease and prevent some of those secondary outcomes down the road. So this is exciting work that we're doing in partnership with our local health department. The other thing is that if we have visualization tools and we have data and information that are integrated and harmonized, we can then start to address health equity issues. This is something that public health agencies all across the country are very fired up about doing. And so we have one example where we did this during COVID to help our local health department find out where there was emerging disease at the kind of neighborhood level so that they could drop in a testing facility or a vaccination clinic to address that in areas, say, of high Hispanic population or high African American population, or some other population of interest to our health department, so they could address that. But now we're trying to use those kind of approaches for health equity across a range of diseases post-COVID. And so that's the power of what data and information systems can help us do. I did want to also point out that our work is, again, not just localized to Indiana. Our global health informatics team at Regenstrief is supporting something called the Open HIE initiative. This is something that is open source, global in nature, brings countries together to talk about what they're doing in sort of creating data exchange and facilitating information sharing within ministries of health. So this is an example of a story that comes from Nigeria about some work that they've been doing within that country. So within Nigeria, the Ministry of Health, along with the PEPFAR program from the U.S., which is part of the Agency for International Development, and the CDC, along with the University of Maryland, Baltimore, all work together to support exchanging data across clinical information systems and governmental systems focused on HIV/AIDS. The question that they were trying to solve is how could they better track individuals who are getting tested and treated for HIV? Very important problem to solve. And so they implemented a system that can integrate data using standard-based approaches that allows them to capture data on the vast majority of people living with HIV in the country. They can then monitor who is engaged in care, who may be falling out of care, who is getting tested regularly and treated then regularly, right? So we can look at the gaps between those who test positive and those who are not in care or not getting treatment, and then try to intervene with those populations. And then they can also monitor viral loads over time for people living with the disease to make sure that they are suppressing the disease, which will enhance their quality of life. So very cool things happening globally, not just in the U.S. Okay, one of the things that is important for us to really be able to achieve all of these visions in the Data Modernization Initiative and what's happening in states and at the federal level in the U.S. Is training. About 1% to 2% of the public health workforce has some kind of informatics specialization or role and training in this. So this kind of skill set will really, if you're interested in working in public health, will really help set you apart from your peers in public health. Also, there's increasing emphasis on building programs in this space. The Office of the National Coordinator for Health IT in the U.S. funded a number of programs a couple years back. Those programs now have various educational offerings to train people in this space. There are other schools of public health interested in getting into this as we move forward to support the aims of the Data Modernization Initiative. And of course, as you probably well know, public health informatics is slightly different than sort of generic health informatics, so specialized training is important to provide. Some of the things that we're doing in Indiana is we're offering some courses this August and every year, virtual courses focused around how to get started with analyzing data using R, SQL or SQL, which is how you get data out of information systems. And then once you get data, how do you use it to make public health decisions effectively? So we're offering 3 courses. These are all designed for people who are working in public health today. You don't have to be an expert to take these courses. This is to help people get some informatics skills that they can then immediately apply to their public health jobs. We are also, speaking of jobs, I did a quick search on Indeed looking for public health informatics jobs and found 256 entry-level positions that are open right now for people with this skill set. These are good jobs. They are going to be, we need people in these jobs in order to achieve the goals at the national level. So I would encourage all of you who are thinking about this as a career to go for it. And those of you who are maybe early in your career to get, engaged with a public health jurisdiction and work on solving these problems. All right, so let's wrap up. Just to recap, public health informatics, I think, is an exciting subdiscipline that has really the capacity to transform our public health systems as we know them today. Second, there's lots of activities in this space happening all over the world. Yes, here in the US for sure, lots of activity, but globally. So if you're interested in working globally, there are opportunities for you. And there's opportunities for new ideas around how we construct our infrastructure and how we design these systems and how we implement them and how we support them going forward. A lot of those things have not totally been solved, so there's opportunity for you to get engaged in this. And then finally, there's growing opportunities for training on this. So if you're like, wow, this sounds exciting and I don't know how to get started, look for these training opportunities and move in that direction. Or if you're early in your career, look for some of these other options. If you're maybe working in medicine now or in a health system, come over to public health. We're very exciting and we need you and your talent. Okay, that's it for my presentation. Hopefully this has been helpful in helping you understand what's happening and what some opportunities are for you. Sorry I can't be live to answer your questions, but I'd be more than delighted to connect with you and answer questions offline later and or connect with you at some kind of upcoming public health informatics event. So hope you have a great rest of your conference and a great rest of your summer.
Wonderful. We're appreciative to Dr. Dixon for that presentation. So we will move forward. We have our next speaker here, hopefully ready. We have Blair Hirst, and I'm so sorry, I meant to ask you how to say your last name, but Blair Hirst is the founder and CEO, builder of and startup advisor focused on launching equitable research, products, and investments with the digital health market. Blair has been a product leader at some of the world's most innovative hospitals, AI, and health tech startups, always building towards health equity and patient centricity in their work. Blair holds a bachelor's in engineering from Brown University School of Engineering and a master's in technology and innovation from NYU Tandon School of Engineering. I also want to point out that immediately following these presentations, there will be a Business Innovation Network chat. So stay tuned for that, followed by final announcements and conclusions. So thank you so much, Blair. Welcome.
Are you all able to hear me?
Yes.
All right, let me get this presentation up for you all. One moment. I have a Microsoft computer, so my day has been a little bit wonky, to say the least. But I think I'll make it through. Okay. Share my screen. Carmen, thank you for that wonderful introduction. And thank you for inviting me here to speak with you all. So I want to talk to you guys about digital health equity and how to build digital health innovations that can change the world for all. Again, by way of introduction, my name is Blair. I have been in the healthcare industry for over 15 years. Building everything from software to data, as well as AI products for a variety of healthcare stakeholders, primarily healthcare systems, research institutions, providers, and patients. And I've done all of this under the interest of using public health and health equity as a basis for digital health design. So I want to start off with one of my favorite quotes by MLK. Of all the forms of inequality, injustice in health is the most shocking and inhumane. And I love this quote mostly because I feel like a lot of the issues in the healthcare system can be solved. It's very humbling and exciting for minds like yours, young minds, to be interested in this field, as well as being the next wave of innovators when it comes to public health and digital health. So again, there are lots of opportunities and ways that we can think about using technology to have an impact and value. We can think about it from specific use cases when it comes to indications or disease management, but also some of the more recent hot button topics that have been in the news lately. So Black maternal health is definitely something that we can use technology for, thinking about the increase of colon risk in Asian populations, some of the deficits that are happening in nursing homes, the lack of research around women's health and what does that mean for menopause, which every woman goes through, and things along that nature, such as access to medication. These are just examples. So a lot of the work that I do tackles these large types of issues and distills them down into granular pieces to solve for, and with the mindset of how do you use technology. And I'm going to walk you through the framework that I have used in my own product building, as well as what I currently use in my own firm when I work with other students, builders, operators, and investors in advisement of how to build technology that has a health equity mindset and is going to do more good than harm. The typical restraints right now in healthcare access generally are revolved around three main issues: high cost, lack of insurance, and time constraints. And when I talk about this, I'm talking about what does it take for a normal patient or consumer, someone like you or me, that may have issues with healthcare access to cross over that chasm and to get healthcare access. All of these problems are byproducts of social determinants of health and some political determinants of health. And the introduction of technology in healthcare and the increased use of technology in healthcare of late has changed the way that we deliver care, how we deliver it, when we deliver it, and where we deliver it. And these are all critical factors in what the new wave of healthcare, digital healthcare, will look like. The downside about technology in healthcare is that if we are not intentional in how we design the next wave of digital health, we can inadvertently exacerbate some of the existing inequities and issues that are currently in the system. And so when we think about building technology products with a public health mindset and lens for health equity, there are three main frameworks that we can use to break it down. First is systems. Structures of institutions, both historically and in the future, are embedded with exclusionary practices. Acknowledging that is the first step that we can do. And then we can look at people, who is involved in the processes of creating these innovations. How are the personal biases being involved? Is there equal representation at the table? Is there a lack of communication with patients and providers and insurers that sort of breeds and exacerbates trust issues that already exist in healthcare? And then lastly, there's a huge health literacy gap going on. And we have to think about how are we building these systems, understanding that there's going to be knowledge inequity, gaps in knowledge. Right now, it's currently estimated that around $230 billion are lost each year just on the fact that people don't have enough literacy around their healthcare and their healthcare options. And so wait to get care, spend more time in getting care, use more money in getting care. That could be medication costs, transportation costs, et cetera. All of this is waste, and all of this can be solved for. And particularly one thing that I do want to touch on today is how technology can, in light of all of these things, systems, people, and knowledge, pose harm to patients and to the general population. I'm sure everyone here is familiar with the, in my opinion, annoying rush towards AI right now. I've been working in this field in machine learning and AI and data for quite a while now, so this is nothing new to me. But it is important to say that if we don't address these things, we can continue to cause harm. This case that you're looking at right now is an example of an AI system that was built and launched into a hospital system. The program was aimed at caring for patients that had complex needs. And it was a partnership with hospitals and insurers who were trying to use the algorithm to better assign resources and care to patients. Now, the algorithm made a lot of assumptions and was not vetted. The major assumption of the algorithm was that it demarked and separated patients based on their cost or the cost of their care, the projected cost of their care. The results of that ended up being around 18% of patients who were Black were not assigned appropriate care. This obviously caused a lot of harm. The AI system was removed from active clinical use. But again, if we don't take into consideration some of the embedded things when it comes to systems, people, and knowledge, we can allow technology to cause harm. And the increased use of technology in healthcare is something that we should all be concerned about, not to stop it, but to activate it for better use. And the increase in things like AI in this particular example and other examples are prime examples of why this is needed to be solved for today. So how do we go from all of these theories of data, of building products, of pain points in the healthcare system, of research? How do we go from all of these theories about what has been done, what could be done, to actually building for equity? I want to talk to you about a few ways that it has been done and a few ways that it's been done successfully, and how we build at Digital Health Review. First, if we go back to the fundamentals, solving for systems is going to be really key in understanding how to build out technology in the healthcare system. Healthcare delivery is one of the major areas that I see as an innovation opportunity for the next 5 years to be solved for. We have gotten into a rut of how we've been delivering healthcare, and it is not equitable for all. We can talk about nutrition deserts, we can talk about food deserts, we can talk about care deserts, the list goes on. So we need to expand our healthcare systems, develop approaches around healthcare delivery that go beyond the existing traditional methods, beyond a patient going in from their home, driving somewhere to a clinic or to a hospital, the traditional healthcare delivery system that currently exists. We saw a little bit of this during COVID when things had a large shift to telehealth. And now we're seeing a little bit of retraction from that post-COVID, given a lot of policy changes that hasn't supported the continued use of telehealth. And the poor health outcomes have already been documented around this lack of new healthcare delivery systems. So when we're thinking about building technology solutions, we really need to think about innovating on how we expand our current healthcare delivery systems. And then we need to also build for digital experiences. A lot of the digital products that are out there for either providers or for patients to use, again, are really geared for one large type of users. It doesn't take into consideration folks who are disabled. It doesn't take into consideration folks who may have different financial or educational needs, or who may even have something as simple as inconsistent internet, right? So creating opportunities to access these technologies outside of traditional channels is going to be really important. You may not want to publicize your solution just in the hospital channel, right? A lot of companies these days are using new age social media. I don't have TikTok, but TikTok's a thing. Instagram, thinking about building apps that allow for offline versions so that if you're living in an internet desert and you're driving from one place to another, and you need to access this app, which you have become reliant upon to manage your care, you're not restricted from that access. These things aren't currently done as mainstay practices, but they can be with enough effort. And then lastly, meeting patients where they are. So basics around building for language preferences, building around different disabilities and abilities, as well as cultural differences. These things are all going to ensure that the technology that is being deployed will function in a variety of environments for a variety of people and in a variety of ways. These things will increase engagement, adoption, and ultimately the long-term success of the health outcomes that the technologists are looking for. I want to give you a quick example of what this looks like in real life, right? So let's move from theory. In Northwest Baltimore, there's a founder named Andrew Suggs who understood that there was a population who had a comfort zone. Instead of trying to force the population to speak with providers who they may not have high trust levels with, to travel from one destination to another, Andrew brought his digital health solution into a barbershop, a non-traditional healthcare delivery system. He understood the community that he was trying to serve, and he met them where they were. And he has been able to tackle health disparities because he has used a lot of the understanding of these communities to cut out the barriers of trust, to increase their compliance and engagement around these tools, and to see the outcomes that he was looking for. And so his tech was really providing early screening and health recommendations for Black men. He understood that Black men, traditionally in some areas, religiously go to the barbershop, right? And that could be a place of comfort, a place of community, a place of conversation. What a great opportunity then to start talking about health and how they're managing their health. So this is a real life example of how to build a technology solution and thinking about innovative ways for healthcare delivery. Going to the second pillar of the framework, solving for people, let's talk a little bit about that. So in my realm of the industry, I am building products that, again, are hitting large hospital systems, having to integrate with multiple systems, EMRs, clinical decision systems, apps that are being used on phones, things that have to communicate with outside bodies, as well as building for folks who are looking at these technologies from a monetary perspective, to be quite frank, investors, right? How well would this product do on the market? There are going to be times often where the forces outside of solving for the healthcare problem are going to pull you away from building around the patient and their care needs, and instead building for outside stakeholders. And when that pressure comes, the best advice that I always give is to stay true and still do it anyway. Build for patient centricity, because at the end of the day, you need patients to use your tools. And if you lose sight of the patient, you'll lose sight of use. So don't build for headlines. It's very cute and it's very popular to see folks saying, I've raised $5 million in funding, or this company just launched a partnership with this hospital system, or they brought in this new fancy tech exec. All those things are great for product expansion, new customer opportunities, et cetera, but they can be distracting. And so fall in love with the problem that the patient is facing, not necessarily with the technology to remain flexible, and stay away from just building for headlines that seem like it's going to garner attention. And then secondly, think about going to market locally. Digital health companies these days are primarily focused on survivorship. Survivorship means getting access to a lot of patients, a lot of partners. That has really been focused on two main channels: employer markets. How can I get my product, my technology in the face of an employer who's going to send it to their 30,000 employees? Or life sciences. And while these are all valuable pathways to choose, there's a lot of value also in thinking about launching locally with local partners, community centers, okay, food banks, again, non-traditional healthcare delivery system, religious organizations, churches. These are all valuable partners within the community that can help you better solve for the patient's needs. So community-based launches provide greater opportunity for impact and learning. Community hospitals are still great partners as well. Think about building technology solutions that can attack the problems of these types of caregivers, local caregivers first, and then expand up. And then lastly, be transparent. As hopefully we all know here, because we're all students of healthcare, there are huge trust gaps when it comes to healthcare for a variety of valid reasons. And so when we're thinking about how can we educate the population on the tool or what we're trying to solve for, being transparent as much as possible is going to be critical. Be transparent when it comes to how much your solution is going to cost. Be transparent in making sure you're getting informed consent. Be transparent in your algorithms. How are you building them? What models were they trained on? What was the data that you trained on? The business partners that you're using? What are the data collection methods that you're using? And what is your mission? All of these things are going to be extremely important. And in my viewpoint, and from the market, it's showing also that consumers, patients, you, me, we have advocacy, we have rights, and we're understanding that, and folks are advocating for it more. So companies, while it's not necessarily mandated yet on a regulatory standpoint, companies are already feeling the pressure from consumers to be more transparent. And so if you think about this early on and tackling these issues and documenting what you're doing and why you're doing it, then the transparency issue will be very easy for you to address, and you'll be able to garner trust and deeper trust, which again leads to better engagement and ultimately better outcomes. Another example of what this looks like, I want to talk about this wonderful founder. I've met her a couple of times. She's the founder of this company called City Block Health. Her name is Tonya Yaja. She has built a tech-enabled healthcare service company that is servicing as a primary care facility in Brooklyn, locally, right? And they started in primary care. They're expanding out. They have been incredibly transparent around their practices. They built with local partners. And this has, as you can see, garnered a lot of success in their technology, as well as shown from A to B concrete examples of how their technology is improving health outcomes. And so it's a win-win for all. They're transparent as a company. Their consumers and patients are getting value out of their service. And investors are seeing the value in health equity efforts and doubling down on health technology that's solving health equity efforts. And if you don't know her, I really suggest that you check her out. All right, the last pillar, right? Solving for knowledge, which is a very, very big issue. So when we're building learning engines, and when we're thinking about all of this, we want to start thinking about how are we building learning engines and sharing your knowledge. Building products in a vacuum is not helpful for anyone. Ensuring that as you're building, you're also thinking about how to share what you're doing across a variety of stakeholders is going to be incredibly important. So how are you deciding early on what are going to be the outcomes that you're measuring? What data are you collecting? How can you be intentional about the data that you're collecting to up the value of the databases that you're building that you can use for your training models, right? Collected data that proves clinical value and tracks impact across demographics is a perfect example of how to measure for outcomes, and building a learning engine early on in the process. And then educating your audiences, providing resources and support to empower patients and caregivers, and their care is going to be critical. This goes back to the trust issue, but it also goes back to this learning, this solving for knowledge issue. Health literacy is very poor in the US. We can improve it. We have the capabilities to do it, and it starts with things as simple as educational resources. I can't tell you how many products I've built, how many companies I've advised, that they're just gung-ho on putting out that product into the market and haven't done simple things as creating how-tos or information packets for patients and their caregivers so that they can give to them about what that tool is or why it's important for them to sign up for the initiative so that they can get their data into the system so they can get better care. And so this lack of knowledge, again, sort of breeds mistrust, and it doesn't help, but these are things, again, that we can solve for. So knowing that this is something that you should be doing early on would be really helpful. And then lastly, in building these solutions, it's really important to think about it in a way that's less competitive and more concerned with partnering. Who can you partner with to fill in the gaps of the solution that you're currently building? We don't always have the answers. One of the best things I've learned in both of my engineering degrees, both of them being interdisciplinary, is that there are lots of helpers out there, and you just need to connect them, right? How can we find folks who are working on similar issues or interested in working on similar issues and bringing them together? Partnering with academic centers, policymakers, regulatory bodies, other digital health innovators are going to be extremely important. And what you see now in the market is folks who have focused on partnerships versus only working in silos, are actually able to build stronger products and last longer in the market. And again, as I've said a million times, which increases user engagement, which increases health outcomes. So these things are all very important when you're thinking about building technology solutions outside of a vacuum, right? Make sure you're building that learning engine from the beginning, and make sure you're finding ways to share your knowledge and making sure you're finding ways to collaborate with other co-conspirators in this work. An example of this is finding ways to also differentiate through clinical validation. One of the unfortunate things that is going on right now in the market is that there are a lot of digital health solutions that are solving patients' needs, but have not gone through the steps of being clinically validated. And so that, again, erodes some trust level. What that means essentially is that there are a lot of products out there on the market. I believe about 86% of the digital health products on the market in the US market have not been clinically validated, which means that their clinical value has not gone through any sort of regulatory bodies, clinical trial studies, FDA regulations or approvals, which is a gross misstep, I believe, and something that folks are scrambling to fix. And if we're not thinking about how to differentiate early on via clinical validation, what we are doing while we may be building cool things is just contributing to medical waste. Because at the end of the day, without clinical validation that shows that the technology solution is improving outcomes, these things will be put to the wayside. And so the effort and resources and time that has been put around these tools will go to waste. And that is a sad thing, both for the folks that worked on it, but more importantly, the patients that have started to use these technology tools or relied on them for their care. And that's something that I have seen a lot recently with the funding cycle being a little bit harsher and companies closing. Their populations are no longer able to receive the care product services that they were previously using, creating huge gaps in care. Okay, so a lot of my work these days is with my company, which is a consultancy and venture studio called Digital Health Review. And so we are focused on collaborating. We help folks who are interested in building digital health technologies. We help them turn their early stage ideas into actual scalable and investable assets for health equity. We are particularly dedicated and committed to building digital health technology with public health and health equity as the basis for design, rather than the other way around. And so what does that look like? We have previously worked with a wonderful Black founder. Her name is Jade Kearney. Her company is called She Matters. It is attacking Black maternal health issues. And she was able to come into our firm with her early stage idea, run through an MVP, launch it into the market, use our networking connections to continue to grow it, and ended up building out a product and product vision that was able to help secure $2 million in funding. And again, while this is a flashy headline, the reason why this is important and the reason why I'm saying this is because when it comes to digital health solutions that are active in the market, Black founders are actually receiving less than 0.5% of venture capital funding. And so for her and others to be able to meet market demands, build something that's valuable, as well as something that's investable, is a huge step in sort of digital health, as well as public health and health equity. And as many founders as we can get that have this mindset, we're here to support. And so Digital Health Venture Studio, which is called Sway, is trying to take this model, decentralize it away from some of the industry's sort of red tape and blocked doors, so that more folks who are interested in building these technologies can, and empowering them to do so, and serving as a launching pad so they can get to market faster, so they can have stronger products, and so they can access top talent in our network to be able to build out these tools. And so our whole goal is just to continue to keep replicating these results. So if you are interested in building a digital health solution, either within your organization or within your college or outside of your degree, this is something that you should look into, and is extremely helpful in thinking about how to circumvent, as well as step ahead, some of the hurdles that exist in the capital world. Again, the last bit of advice that I'll say around building equitable health tech is that as innovators, everyone here in this room, we are in a very unique and privileged position to help define what the future of healthcare is going to look like. And in that case, it's very important that everyone is intentional about what we do with that power, so that we can ensure that we are doing as much as we can for the lives that we are going to touch. Okay, that's all that I wanted to say. I wanted to leave as much time as possible for questions around anything that I discussed. I'm going to stop sharing my screen as well.
Thank you so much, Blair. This was a really good discussion and presentation is what I really want to say. Do we have any questions? Thank you. I know we have one in the chat. April, I don't know if you want to come on or I could just read it.
Yeah, the question was just about AI as a, we just hear about it so much in the news and everything, but how can we continue to make it known that we still have to hold on? There are a lot of concerns in the way models are being designed, and that there can be a lot of harm when we exclude diversity or we target diversity. There could be some very negative, dangerous implications. How can we continue to spread awareness of what AI can do and what we need to research before proceeding?
That's a great question, and sorely needed. So I would say a variety of things. Right now AI's continued use is sort of at the apex of corporate innovation, Microsoft, OpenAI, Google, regulatory bodies, the FDA, CDC, EU regulators, China regulators, which are way more stringent, and then innovators like everyone here in the room or other founders. I would say that the best thing that you can do is to try and embed yourself with any of the initiatives that are going on around responsible AI use, signing up when there's open calls for input. Light Collective is a wonderful organization that is focused on patient data rights and ensuring that AI is built to ensure that patients are maintaining their data rights, especially as healthcare data is turning into dollars, and it's not sort of trickling down to consumers whose data is being used, but they're not getting the benefit of that. Digital Health Review, my firm is also in the process of running a research project with UCSF Berkeley and Harvard and other institutional players. It's on our website. We are looking at epistemic injustice in healthcare AI. Anyone interested in participating, please sign up. Open call and enrollment closes at the end of August. In this work, what we're really looking at is highlighting the fact that medical research and education has been built on incomplete databases for a variety of reasons, intentional or not. We're not there to point figures at particular educators or institutions. What we are looking to do is to outline these databases that are incomplete and how they're being used in AI models, as well as showing that by understanding the epistemic injustice impact that AI models can have, we can look at opportunities in the market to build other models to solve for them, right? So that's where that investable asset goes. So I would say, try and get in with the regulatory bodies, try and sign up for any open calls that are doing this research around responsible AI. And if you have access to data that you can share or use to show sort of the opportunities and potential harm, go ahead and start that research project and publish those results.
Thank you.
Any other questions? I had a question, also thinking about the idea that we are looking, public health, unfortunately, tends to be kind of on the back end of issuing in some of these new technologies and new things like that. So it's not completely unbelievable that we may take some time with AI and things like that. And so what are some of your thoughts, which I know there are health departments, I'm not like down on health departments, but what are some of your thoughts about how to bring this in with this? And I know you did a whole presentation really giving us those, but specifically public health agencies, public health departments, what should they be considering as they're thinking about bringing in AI to public health? And a lot of the tools that they do a lot of things with surveillance and things like that. And so just some like quick ideas and thoughts around that.
Apologies, I was on mute. Yeah, absolutely. There's a variety of things that you can do. For starters, there are groups that are in desperate need of advisement from public health leaders. So, for example, when I am building a new company or a new product, we are often looking for subject matter experts when we're thinking about early product design. You can put yourself in a position either through network systems. We have one at Digital Health Review. There's others out there also to basically raise your hand and say, I'm a public health expert. I'm working in sort of data modeling, AI, ML, so that when these companies and these innovators are thinking about it, you are the person to call. And you also ideally would have colleagues in an institution behind you to do that as well. Secondly, I would say, another way for you to think about integrating AI solutions in a public health context, and this goes back to the transparency point, is really making clear what you're trying to get out of the data collection. One of the biggest faults around AI models is garbage in, garbage out, right? So you can have a large data set, you can have a large model, but if the model and if the data wasn't collected with the research question in mind, you're often not going to get out the results that you think you're going to get. And so there's a gap right now in AI development where we're using open source data, we're using open databases that have been collected for a variety of reasons, and we're not considering the context of this. We have a podcast where I was just recently speaking with the founding member of AX by Design, where they are looking at anti-racist development around AI, and they really dig into like decontextualized AI is just as harmful, right? If it's not within the context of why you collected that data, it can cause harm because the outcomes aren't going to match up to what you're expecting, and you're bringing in sort of invaluable data to what you're looking at. And so all of these techniques and mindsets around what you're doing is going to be really important in the building of the model, not just using open source models for a variety of use cases. And you should take a listen to the podcast, because I can't speak to what Poi Palin, who's the founder, is an expert in, but she definitely talked about how to think about decontextualized data, how to think about prompt engineering, prompt etiquette, which is going to be really important as well. Why sort of, different perspectives are really important, because it changes how you are pulling out information from AI models. Simple things as language, right? We had a conversation about how, how I'm originally from the South, how I may speak with my family members is very different. And if I am prompting an AI model for information and I'm using colloquial language, again, it could give me a different result than someone who may be using a language that is primarily used from a normalized lens that the AI model was built under. And I'm putting that under quotes because all language is normal, but there's a predominant way of speaking in this country and using models.
Yeah, absolutely. I think we were having a discussion earlier, and I guess we've kind of moved into our networking session. So thank you again, Blair, for the presentation. And so feel free, you all to ask other questions and discuss. We were having a discussion earlier with Dr. Reed had mentioned how, some of the skills that some of the students are not coming out with in public health is that we don't even know how to collect data. And so I was listening to you saying like this data in context and having, we've had this collection. And so a lot of times we're using this secondary data or we're doing secondary, what do they call it? Yeah. Anyway, we're analyzing, data that we did not collect. And so, and definitely not thinking, and although we put different things on there, like this is the context, but I wonder if it would help even as we're collecting it, if we have more of this messaging, like really describing this is the context and where this came from and things like that. And so I guess, this is where we are. How can we make that better? I imagine everybody can't go out and collect these large, 10 million people worth of data, but what are some of the things we can do to kind of help with that issue? Like we have to use secondary data.
Yeah, I hope I didn't misspeak and say that secondary data was not
no.
valuable at all. That's not what I meant to say. I'm working with a model right now that's, looking at clinical notes, over 50 million patients. And there's definitely ways to think about it. This goes again back to sort of the knowledge and the transparency, being very transparent about the research question that you're hoping to get out of the data. Being very transparent with the folks that you're giving the outputs to around what that research question was, what were the data types that were used, what were the data fields that were used, how did you build the algorithm, How did you test the algorithm? Again, not to say that every algorithm is going to be built perfectly or the outcomes are going to be perfect, but it allows folks to then frame the outputs around context as well, right? They were surveying 50 million, they were surveying 50,000 patients in the Midwest, right? So there's geo input here that we need to take in consideration. Is this population going to then be applicable for, you know, the Northeast or the South? Probably not. But because you were transparent about it, and what you were looking for and where you got the data and who was involved in creating the data and how the data was created and what systems it hit, it allows for context to be put around the work to make it easier to draw conclusions around the value of those outputs. So context is king, I would say.
Yeah, I agree. I think about those times when we're looking at a survey, looking for quantitative insights. And, just even as a researcher, when I'm looking at some of these surveys, just like the way that the question was asked, it's almost like there are just so many things that could happen where, there was only one answer that I could really give to you. Or there's a situation where none of the options made sense. Like none of them applied to my circumstance. So I just chose anything, right? And then of course there's also the context where like, I don't have time for this. They just want me to do this. I'm going to get $5 for this. I'm just going to click anything. So, there's a lot of opportunity for researchers to understand. I'm big on the qualitative piece, and I really feel it's like hugely underdeveloped. And then also, how can we, speak to individuals, potential survey responders, to find out if the question was even framed correctly. I don't think that part is done very frequently. We may ask for validation among experts to look at the questions, making sure we're asking, the right topic types of questions. But how often do we reach out to potential participants of a survey to make sure that those questions were asked and framed correctly?
Yeah, I agree. I think this goes also back to building with community, right? Thinking about different ways to do healthcare delivery and systems. There's been organizations that I've worked with that have formed patient advisory committees that have worked with researchers to draft the surveys. That is an excellent way to start thinking about it, as well as a body that you can go back to check your work. So I'm a big proponent of patient advisory committees. I love them. My sister has sickle cell, and so she sat on a bunch of them as well to give her perspective for a lot of things. And she found them valuable as a patient because in the clinical context, she didn't feel like she was being asked very often her opinion around things. And so as much as you can get all the stakeholders involved as early on in the process, that could potentially help mitigate some of these things.
Yeah, and then also like when it comes to the community piece, making sure that the community trusts the researchers, right? Because we get these opportunities. I'm also part of a patient community, and we get these opportunities to participate in research, and we don't trust the researchers sometimes, so we don't participate. We choose not to. So yeah.
Yeah, that's great. Any other questions? Any other thoughts? Is anybody else working with AI or technologies that are using AI? Anybody scared of AI?
Definitely very scared of AI. Saw a recent article about how one of the I can't remember which of the the DNA sampling was being bought by an organization. I'd have to look for it again. I think it was the one where Ancestry was recently purchased by kind of a suspect organization. So yeah, just who owns our data?
Oh yeah, we know a lot of a lot of companies are kind of coming in, taking over. I think about, which this is not necessarily new, but Amazon and the prescriptions, now and things like that. And so really interesting in a lot of ways. Yeah.
However, I am using the Noom app right now because I'm just trying to get back to my, pre menopause-ish body. And yeah, it's actually really good. And I know there's like different types of AI, there's different levels to AI. I really like the app. And I mean, it has a very defined scope, of how it's using AI versus like, I'm going to just bring in everything from the universe of the internet. But yeah, I think, if we're talking about fixed parameters, feel more comfortable versus like something that's going out into Google and creating.
Yeah, are they very transparent on their
I don't
oh,
know.
I was just thinking about you talking about parameters and I was
Those
like, they
days,
say
they've got my
expression.
weight and they've got everything right now, so I don't
Gotcha.
know.
I'm curious, April, do you feel, it sounds like you like it. Do you feel informed on what they're doing or what they're collecting, and you feel comfortable enough to use it, obviously, continue to use it?
Yeah, I'm hoping that I'm not sharing information beyond what, my weight and height is. Maybe the things I'm eating, I'm okay with that level of information, but I'm not sure, to be honest with you. Like, and even with my cell phone, how much it really knows about every detail of my life. Yeah. But I do like it. I think it's very beneficial in terms of like helping personally log things, like how much water and how many steps and things like that. But yeah, it definitely, actually, I don't know if any else of you have used the Noom app, but it does ask a ton of questions at the beginning. So it's like trying to, create this model for you or whatever, but it's like it does ask a lot about your behavioral, habits and things, that the way that you seek information and the way that you know, actively, go out there into the world, your habits. But it starts out asking tons of questions, but they don't seem personal. They seem more like, okay, are you more likely to, eat when you're stressed, or, like that type of thing, versus like, how many children do you have, or like, where were you born, kind of thing.
Hmm.
Yeah. So like that, I can think of that as being one example so far that seems okay. Like if we're looking at a fixed parameter of data that it's working with,
Yeah.
just range.
Yeah, I've seen a variety of companies that have done it differently. It sounds like they have a very thorough onboarding process for you, which I'm impressed that you're still using it. It's usually a drop-off point for folks. But yeah, some some companies are very transparent. You can go into their website, into their FAQ sections, and they will tell you, this is the data that we're collecting. You can go into their privacy policy. You can see that they may be passively collecting location data. So even if they didn't ask you for it, they may know where you're going or where you live. And that could be helpful for them in a variety of reasons. They'll tell you who their partners are. We collect analytics data from Google and Facebook as an example. But it allows for what we would say in the clinical research world as, informed consent, right? So it's less about, I think it demystifies the fact that folks have data, brings it up to the forefront, it educates them on what is being collected, but most importantly, why they're collecting it. And the folks that do that really well tend to have better engagement. And clearly you're an example of what that looks like for someone who knows or who went through the process and still decided to opt in.
Yeah, I'm curious to hear what other people's views are of AI. A lot of my coworkers still think it's the greatest thing, and the media team seems to think it's the greatest thing, that the future is AI. And it's going to replace us all.
This is Heather Reed. I had a very interesting interview with a physician who's now doing a PhD in ML and AI, and interviewed me sort of about core workflows as being a physician, and I essentially summed it up being a primary care physician. I said, well, you have to take in all the data and make a decision about every 10 to 15 minutes. Got to get to know someone, try to understand their whole life, try to understand all their health problems, make a decision about 15 minutes, and then you have to be their mom. You have to try to make a relationship and try to get them to do the right thing. For those of you that are mothers out there or had a mother that, and everybody knows that that's a very difficult job, right? Because, that patient has autonomy, they have a whole life, like they can take in what you have to say, but they've got to incorporate that into their real world, right? And how they live their life and what's meaningful to them. And anyway, so, I think she walked away from that and later wrote back and said, I don't know that AI is going to conquer this. I'm not sure that an AI will ever be able to be a mom. And so I think that I think we all should be appropriately afraid of AI and very afraid of its power. But I think we also should recognize that there's no way that AI can replace the complexity of what human beings navigate and what we bring to the workplace. And it's our job to train those models to be as good as they can be and to help us out as much as they can and hopefully not do harm, which I think, Blair did an amazing job in talking about the harms that can be done. But they're not going to replace, the complexity of the human experience and all of the things to really navigate the human experience.
You for sharing. Yeah, that's good. And the comment from Dorothy that says, I embrace AI, but with human oversight. So definitely, we always have to have those checks. I mean, we have to have those checks and balances with humans too, so I'm just continuing that on. Go ahead.
No, I was going to say, absolutely. The checks and balances are needed over humans as well. So, and all of the institutions and, complex things that we've created. I was just going to say, we don't use AI in the small tech company that I am, that I work with, we don't use that much, but I think we will use more going forward. And it is helpful for example, very mundane processes like teaching, the computer, and you can tell I'm not a programmer, but essentially teaching the computer how to clean data, right? And to look for patterns of, addresses. For example, in public health, we have, horrible issues with addresses. I know that sounds so mundane, but it's so true. And, and reconciling two patients, making sure they're actually the same patient. Is the person that got COVID the same one that comes down with long COVID, or shows up in the record 6 months later? Is it the same one that files disability application another 6 months later? Is it the same one that shows up in your occupational database, that was exposed, 6 months prior, right? You've got all this reconciling of human beings across data sets. And so one of the things that we focus, or our team focuses on, is just trying to leverage the power of AI or machine learning to do some of these processes, which otherwise take hours of human time.
It's a great example. And to that same idea, I was just trying to look in the data for emergency room data, and I was trying to find out, why are people going to the hospital? And the way it's written in, like, left arm versus L arm versus LT arm versus, whatever anybody wants to put, LA, and so, yeah, reconciling all of that. When I tell you, I spent hours and hours trying to figure out how to put that all together. So definitely. Sorry, Blair.
Right. And that's a lot of, medical school is just, training a brain how to read all of the abbreviations, right, that we use in nursing and medicine, so that we can read other people's charts, and our brains learn to do it. And so 10 years into practicing medicine, I don't have to pause that much, right? Actually, I'm older than that now. I'm like maybe 20 years, but at any rate, but the idea is, your brain learns that, right, over time. And so you can process, and I can go very quickly through charts and pick out, pages and pages of what's important. And so, yeah, but to teach a machine how to do that, right, would take quite a lot of work, but would be incredibly valuable, if we could teach that machine how to do that.
Yeah, absolutely. I love that example that you gave, Heather, too. And you as well, Carmen, because one of the models that I'm working on right now is basically, it's scanning clinical notes and doing a lot of that hard work to pull out the insights and the trends, because it takes hours. And then Heather, to your point, I think that's a lot of probably what we're going to see as far as integration into large scale healthcare systems outside of these, innovation groups and, outlined cases, is more back office to front office versus front office to back office. And I actually do think that is probably going to be the best pathway for trust building of providers and patients, because you have to, a lot of these things are being built under the guise of clinician decision support, which I've built a lot of clinician decision support tools. I see the value, and I want to get rid of these like 20-minute, mandates that physicians have to go through and worries about utilization, and help them. But there is a lot of value in using AI to get rid of some of the back office workflow issues, right? So maybe it's not patient facing, maybe it's not touching patient records, but maybe it's an AI that can build out those educational tools very quickly for you, right? Maybe it's an AI that can, test out certain scripts so that people can call to patients and get them to actually answer or come in. I myself, I have 3 kids. I use an AI tool to manage my calendar and all of their many things, right? And would I use AI for every aspect of my life? No, but it's very nice for me to put something as a task or an event. And if something comes up, it gets moved to another slot. So I'm not forgetting things. So I'm showing up at the right time and at the right place. And while it's not sort of front and center, it's not going anywhere near my finances or anything like that, it is helpful to day-to-day stuff. So I've seen sort of early use of AI for clinician decision support, unsexy things like, pre-authorization support, sort of these things that, are the foundational things that keep a healthcare system running, that keep a practice running, that no one really talks about. The use cases there are very strong. The harm I can see mostly is on the patient facing or the clinician decision support side. And it's, as long as we get a handle of that, then we can sort of phase it out and integrate it into that area, in my opinion. And hopefully I didn't give away my age. I have a baby face, so, but I do have 3 kids, and I do enjoy AI for household management.
Yeah, certain purposes. All right. Thank you so much, Blair, for your presentation today. There's a lot to think about as it relates to AI and technology and how it can benefit us for health equity. Thank you.
Okay, well, take care, everyone. Thank you.
Yeah.
Thank you.
All right, Carmen, we're here. We've made it to the end of the day.
Thank you all so much. Many of you stuck around the whole day. We really appreciate your input and your time and energy. I just want to remind you that you can get information from last year's conference that's up, and then we'll do the same thing for this year's summit. We'll have that available for you. We'll send you the link once everything's ready and things like that. So thank you again for that reminder. You want to talk about this, April?
I'm trying to remember the reminders. I mean, please do sign the survey. I saw a few of you sign the survey. Thank you so much for your feedback. It's really important as we work on how to improve things for the following year. So yeah, I mean, next year it's a 3-day event, just like it was last year. So very curious to, know your thoughts on that. Maybe this one was, it was 1 day, but it was very dense, right? Densely packed. So maybe we can figure out how to create the 3-day, maybe in a way that's not as densely packed or something. Yeah, if you are requesting a certificate, we can provide that to you.
And then also just a quick reminder, I'll go back to that feedback form, but We just started the Fiat Insight, and so our new blog, you can check that out. It's exciting. We already have some posts up for you to check out, as well as our intern who talks about her path into public health and ethics. We also have a recent publication on the PHIAT conference from last year. And so if you want to read more about that, that's available as well. And we'll send these links out to you. And then again, our feedback form. Thank you again for those who attended. As we said, if you want, I will be sending out the certificates that I know about. And then if there's anyone else who would like a certificate of attendance, I'll make sure to get that to you. So thank you for spending the day with us. We hope that you learned something and that you are inspired. And we look forward to seeing you next year.
And lastly, a final thanks again to our interns who have been volunteering with us. We've got Tanya and Delphina still here with us today. Thank you to Coco as well for all of your help over the years and working with the publication. Again, we have our upcoming publication, I believe it's with JMIR Publications on the PHIAT conference. And then lastly, again, the upcoming PHIAT Insights podcast. If you're interested in being interviewed, please reach out to us. You can reach out to me at april@publichealthpodcasters.com. We can arrange to interview you for PHIAT Insights. Podcasters.com, putting it into the chat. Okay, thanks again so much for participating today. And we do have the recording. We will have to edit a bit of it, the LA County piece, that part. Yeah, that region. But thank you so much.